can you walk us through how we would tackle vascular occlusion using Radiesse?
Yeah, of course. So this has been like a really big area of research for me. So we've really spent a lot of time trying to answer this question and study this. But I'll start with some facts. I think that the overall incidence of VOs with Radiesse is probably a lot lower than most people think. So I think a lot of people assume or they conflate that, okay, it's not reversible, therefore it must have a much higher vascular occlusion rate. It's actually not the case. And there's a really good article in JAMA Dermatology that actually looked at this over injections of Radiesse. And the rate that they found was about 1 in every 6,500 syringes, or a rate of 0.016%.
Wow.
And the study also found, not surprisingly, that the rates decreased even further with cannula usage. And some of our own research, Dr. Suarez and my research, showed that there was a decrease in occlusion rates by dilution. So even the addition of a small amount, let's say 0.26 mLs of diluent, appears to correlate to a decrease in the recorded vascular occlusions. Okay, well, what do you do when it actually happens? And the immediate answer is hyaluronidase is not going to enzymatically dissolve any biostimulator. It's not going to dissolve CAHA from Radiesse. It's not going to dissolve PMMA or PLLA. So there is still a risk that is slightly more complex than dealing with a vascular occlusion with an HA. But let's break it down. So the gel component of CAHA is not chemically cross-linked, which means it's miscible in water. You'll see people dilute it, and that gel sort of homogeneously breaks up. And some of the research, actually, your publication that I'm about to cite with Dr. Suarez, showed something really, really important to us, which was in the case of Radiesse vascular occlusions, it is likely that almost all of them incorporate some element of distal embolization. The CMC gel is likely, if it's undiluted, is likely staying in these smaller chunks mixed in with calcium hydroxyapatite. If even a small amount of dilution is added, again, I'll say 0.26, that is almost eliminated. And now you're just dealing with the CAHA microspheres as the embolic agent. So that leads to the next question. Okay, what do you do? So on the chance that the injection was a large bolus of undilute Radiesse, it's probable that there is some element of a proximal vascular occlusion. And some of our work has shown that obviously at some point that will distally embolize anyway. So it makes sense, in our opinion, to target the whole affected angiosome. So potentially across multiple tissue layers. Still, the recommendation is flooding with hyaluronidase. And I think this eliminates the guesswork of where is the actual blockage. Okay, now we have microspheres. They're sitting in these smaller vessels or capillaries. What to do? And the protocol is not drastically different from an HA occlusion. I should also add here that the amount you're injecting, the bolus size, has a direct correlation with the embolic load. So the amount of embolic material circulating in an angiosome. So anyway, if you see blanching, or if someone is like, ow, that really hurts, or there's a sudden pain, stop injecting, massage the area, and immediately apply warm compress. And by the way, this is all published in a really, really solid article by Yanni van Loghem. But I think a really critical step in treating biostimulator VOs is actually aspirin and vasodilation. And right, you're not going to dissolve the filler material itself, but you can think of an occlusion, I think, as two components: the material, so the filler, and the biological emboli, right? So fibrin plugs forming, clots forming. And once flow is stopped behind a filler, now you have a second added concern. The good news is especially with a biostimulator, you can target it with aspirin. So antiplatelet therapy, vasodilation with a PDE5 inhibitor should decrease the perfusion deficit. So I think those are recommended and I think critical, especially again, when you're targeting the, I'd say, biological component of the vascular occlusion, that appears based on published studies to be the highest yield for biostimulatory occlusions. It's still recommended to use hyaluronidase. The theory behind it is that it may increase permeability of the vessels. This is something that's kind of debated a little bit, but it's still recommended in the literature. So whole angiosome, hyaluronidase, but keep in mind that it's not going to directly impact the CAHA or the PLLA or the PMMA or whatever is still there. And so sort of rounding that out, all right, you're checking cap refill, you're looking for reperfusion. Let's say that it's been days and they present days after and it appears necrosis or skin breakdown is imminent. So that's where I think adjunctive therapies are also really beneficial. Hyperbaric oxygen, maybe growth factor containing topicals. Some of the literature also recommends dose tapered oral steroids, even antibiotics, which I think would be contingent on necrosis and infection. But all of that being said, there are a lot of options in treating this. Again, it doesn't vary dramatically relative to an HA occlusion, but I want to really emphasize how important something like aspirin, or even in some cases, low molecular weight heparin, maybe in devastating cases, might actually be. And I think, for example, we looked at an animal study earlier this year where over 60% of the actual occlusive plug was not filler material. So when you're thinking high yield, you got to find a way to either prevent platelets from aggregating or clear up an aggregation of them after the fact. I'm basing a lot of this off of our Pulsar study. And for the listeners that don't know, we at VIP and at Merz established a really cool model to measure and monitor vascular occlusions, right? It's pulsatile, it's physiologically relevant. But in this model, what we found was that only undiluted Radiesse was able to form a proximal occlusion in the first place. So everything else basically fractured, fragmented, and dispersed distally immediately upon exposure to a vessel. But to come back to your question, we did try a couple different techniques in the lab setting to clear out a proximal occlusion, and the best method that we found was massage. And so I think that's why still the literature suggests flooding the entire angiosome rather than just trying to pinpoint it at the proximal injection site.
So that on-label dilution is that 0.26. Can you speak on what happens to the G prime of the product with just that on-label dilution and how it changes from undilute to just adding 0.26?
Yeah, it's a good question. So there are two FDA approved, I would say, Radiesse products, Radiesse and then Radiesse Plus, which has integral lidocaine. And so we'll consider, let's say, Radiesse Plus as undiluted Radiesse. People aren't generally manually diluting that with 0.26 mLs. So the addition of just significantly decreases the G prime of the product. And the decrease is so significant because the gel itself is not chemically cross-linked. So a little bit of admixture of saline or lidocaine can really quickly impact the rheological properties. So you would, I think in the study that we did, undiluted CAHA had about 1600 pascals of G prime, and with the addition of 0.26, I think it's around 450
That's
pascals.
insane.
So a really big reduction really quickly.
You can feel the difference, just that extrusion force, that push of undilute Radiesse to just adding that 0.26. It's profoundly different in the push, for sure.
Yeah, I agree. By the way, I just pulled it up. So the addition of 0.26 will drop the G prime from around 1600 to around 500 pascals. This is a
That's
huge reduction.
incredible and profoundly would change how, in theory, the risk of a vascular occlusion just by adding that 0.26, you would think, with that proximal occlusion, right?
For sure, from the proximal occlusion aspect, but I think there's
Right.
a second consideration here, which is again, I'm going to cite your paper again. It's a good paper, by the way. Congrats. But the volume of injectable microspheres is really, I think, a
Right.
key driver. So even if you're adding, let's round up, zero point 0.3 mLs of lidocaine, you're decreasing the number of microspheres per ml.
Right.
So every cube of skin, every angiosomal territory has a certain amount of embolic load that it can tolerate without an ischemic injury. So the key is figuring out, okay, at what point has a sufficient volume of embolic material been introduced to cause an ischemic injury. So on one hand, yes, a small addition of 0.26 mLs of lidocaine might really decrease the risk of a proximal occlusion, but simultaneously it's decreasing the number of microspheres per milliliter of injectable. And I think that's a really important
That's why
point.
that's why I never inject more than zero point 0.2 cc boluses at a time. I'd rather have to stick my patient a couple more times than inject this large quantity of any product that I'm using, whether it's an HA or a biostimulator. I place small threads constantly moving my needle. And in the past, we were taught when I first learned about Radiesse was using sodium thiosulfate to treat a vascular occlusion, but that has quickly fallen out of favor as far as vascular occlusion protocols. Can you speak to that?
Yeah, this is a really good question. And, it's something I think that's still really important to address. I get this question virtually at every conference where I'm going to talk about nodules or vascular occlusions. I think that there were some preliminary signs, some case reports suggesting that sodium thiosulfate might work for nodules and it might work for vascular occlusions. And for some background, the reason why that was theorized is because sodium thiosulfate, STS, is a calcium chelator. So the theory was to pull out calcium and basically break down the microspheres. So, just to add again real quick, you really can't study vascular occlusions in humans, right?
Right.
No IRB
Right.
or regulatory board is going to allow you to do a study like that. So all of our sort of data that we have on this is coming from animal models, our pulsar model, or case reports. So probably around 10 years ago, there are some case reports on sodium thiosulfate potentially working. Merz did the appropriate thing and they actually carried out a very well done animal study. Unfortunately, what they found was that the effect was due to the aqueous dispersion
Right.
of the particles rather than an actual reversal agent. Now, that's fine, but sodium thiosulfate has its own sort of potential complications, like hemorrhaging and increased inflammation. And so the study that Merz did basically, I think, showed that there was no material effect on the CAHA, but there was an increase in hemorrhaging and necrosis, and that is why it's no longer recommended.
Right. From a Radiesse standpoint, it was pretty much equivalent to using normal saline to disperse it, but with tremendous downside as well.
Exactly.
Yeah,
Exactly.
so it's completely fallen out of favor, and what I'm usually teaching in my trainings is to really, like, from a very simple standpoint, is when in that situation, treat it exactly as you would an HA occlusion. You still flood it, you still check cap refill, warm compress, massage, aspirin, rinse and repeat, check cap refill until you get that restored blood flow. So there really is no difference between an HA vascular occlusion protocol and a Radiesse protocol, is there?
No, I don't think so. You'll see, you'll see, I think, in the published literature, their protocols sort of mirror each other. The only thing, the only difference is I think there should be a really strong emphasis on the aspirin or even the pentoxifillin, which is also recommended in the protocol. So again, going after not the material part of the occlusion, not the filler material part of the occlusion, but actually, the propagation of a clot.
Yeah, I think that needs to be brought up more in lectures and trainings, because I don't think your average injector is really understanding of that. They think that there's only a proximal occlusion, so we just have to clear this proximal occlusion. And I think there's it's very simplified in our industry. As far as how I was taught in the very beginning, it was, this is where your bolus is, this is where your occlusion is. There's nothing really beyond it. Maybe some things broke off, but really this is the meat and potatoes of what you have to clear. And once you clear this, you're free. And that's not necessarily the case, right?
Yeah, it's funny too. If you go back and watch the videos that we took in Danny Suarez's office, where we're actually doing these experiments for the very, very first time, we're doing them with HA filler. And my assumption was that I was going to see exactly what you just described. Like, a strong HA is going to form a plug. And instead, we saw the exact opposite. And you can hear in the audio, like the very first cycle I'm watching, you can hear me gasp, like, what just happened? Right? You get humbled every once in a while doing research when you think something's going to happen, and then it's the exact opposite, but you're right. As we're sort of slowly picking apart what's going on with vascular occlusions, we're learning more and more.
Yeah, we don't
But
know
yeah,
what we don't know yet.
exactly.
I know, and that's kind of the exciting part of our industry, is that it's really still in its infancy, right? I mean, it's still within like its first like 20 years of really like raw aesthetics, and medicine has been around for hundreds and hundreds of years. We don't even have like a standardized education and anything. Like, all of that will come down the line, but right now it really is still such a baby, and I love the idea of we don't know what we don't know, and how we're going to look back on this conversation right here, and our VO protocol might be completely different down the line because we have this miracle drug that clears everything, or whatever the case may be. But it's so exciting to still kind of be in the infant years of this medical specialty.
Yeah, I agree 100%. And it's fun also being a scientist, right?
Oh, I'm sure.
And in aesthetics, it's a lot of reverse engineering, right? I see this thing clinically, go tell me why it's happening. Oh, that's a lot better than, I have an idea, let me see if it works.
Yeah.
So it is fun also, to sort of help answer these questions that have persisted in aesthetics.